I am Dr. Basundhara Roy. Okay, I'll be your physiology tutor, and today I'll be explaining to you the examination of respiratory system. Okay, it's kind of lengthy, so try to pay attention. And it would be really good if we could interact, right? Any doubts, any questions, please feel free to ask. Okay, so the general physical examination has been explained to you all, right? Today we will focus on the respiratory system examination proper. Okay, there are 5 important steps, and the first step is most important, that is consent. The distance between you and behind the bars is not very far if consent is missing. Okay, take consent first of all. Then we'll go with inspection, palpation, percussion and auscultation. Now to give you a brief outlook of the thing, inspection is what you see. Okay, palpation is what you feel. Okay, auscultation is what you auscult. Percuss, my bad, percuss. Okay, then comes your auscultation. You know, we have an image of doctors with stethoscope. Okay, that is why the stethoscope is there, for your auscultation. Okay, so consent is done. We take the consent, we ask, what is your name, sir, ma'am? Okay, can you give us your consent for conducting the examination? Okay, we get the consent and then we proceed. Very important, don't forget it. Consent is utmost important. Be in the safe side. Take care of your safety first. Okay? Now, inspection. Any deformity, gross deformity or any abnormality you see in the chest wall. Okay, first of all, for respiratory examinations, some of you all will have to volunteer. We'll take consent from you as well, don't worry. You have to expose the chest wall, okay, for examination. First, we'll see the appearance or form of the chest. Okay, normally it is elliptical in cross section. You all understand cross section, right? If there is something like that, I give it a cut and you see like this, this is your cross section. Okay, it is elliptical. It is elliptical. Okay, then comes your chest wall movement. It is, you know, the lungs, we breathe in, we breathe out, right? There is movement. Okay, we'll inspect the chest wall movement. And then very 2 important things. One is your trachea, the one I'm using right now, larynx, trachea. Okay, trachea is very important. Tracheal position can say a lot about a patient's respiratory condition. Okay, then comes your apical impulse. Now, are you people aware about apex beat? No? Okay. There are 2 things. One is apex beat, another is apical impulse. Apical impulse is what you see, inspection. Apex beat is something you feel, palpation. Okay? Okay. Now the shape and symmetry. As I have mentioned, our chest is bilaterally symmetrical. Nature is symmetrical. Nature loves symmetry. You understand now? You have heard this before. Our chest wall is symmetrical. Okay, and it is elliptical in cross section. Remember the cross section? It is elliptical in cross section. Next is the transverse diameter and anteroposterior diameter. This is called the Hutchinson's index. What happens is the transverse diameter of the chest wall, if I'm standing like this is my transverse diameter. If I'm standing like this is my anteroposterior diameter. Okay, transverse diameter divided by anteroposterior diameter, if it is 7.5, that is normal condition. Okay, this is called Hutchinson's index. Okay, then we look for any kind of bulging or flattening of chest. Inspection, you look for any abnormality if it is there. Okay, any mass or anything coming up or anything skin problem, you just see, you just inspect. Don't touch the patient. Okay, once your inspection is done, then we will move to palpation. Now, I have told you about the normal condition, you know, elliptical, bilaterally symmetrical and everything. Let's focus on some abnormal shapes. Kyphosis, okay, forward bending of your vertebral column. Scoliosis, lateral bending. Okay, there are conditions which there are people who have kyphosis, scoliosis. Both the things are there. Okay, forward bending as well as lateral bending. Then we move to barrel-shaped chest, increase in anteroposterior diameter. We see it in patients with chronic obstructive pulmonary disease, and we also see it in patients with asthma. Okay, barrel-shaped chest, remember this. Then comes up pigeon-shaped chest. Pigeon-shaped chest, we see this in rickets. Are you aware about rickets? Okay, anybody wants to speak up? So many yes, ma'am. Stand. You see it in adults or in children? Good. Sit down. Okay, next is flattening. Okay, flattening of chest is called platythorax. We see it in a subtype of interstitial pneumonia. Okay, the name is quite complicated, not necessary at this point. Just remember, we see it in a rare subtype of interstitial pneumonia. Okay? Okay. Now, let's move on to movement of chest. You know the chest is moving. We breathe in, we breathe out, right? We have to look for the rate. Anybody wants to tell me what is rate? How do you define rate? Per minute. Okay, if minute is what we are taking as standard, then per minute. In medical, we generally take minute as our standard for rate. Okay, so rate, respiratory rate and rhythm. Between two cycles, the interval, if it is constant, we say it's normal rhythm. Okay, if there is variation in the interval, then it is kind of abnormal. Okay, sir has very well explained to you regarding tachypnea, bradypnea, right? Tachypnea over how many breathing cycles per minute? More than 20. Very good. Can you tell me one reason why it happens, tachypnea? And one condition where you have seen it? Exercise. Okay, exercise. Anything? Any more? Pneumonia can be. Any more? Hypoxia. Now, hypoxia resulting because of what? Yes? Yes, that is also right. But is that pathological or it is physiological? Very good. So, you people are clear about physiological and pathological. Great. Very good. Now, let's go for type of respirations. You know, thoraco-abdominal. What do you think it is? Thorax, abdomen. More involvement of thorax than abdomen. And the reverse, okay? Abdominothoracic. Okay? In females, we see thoraco-abdominal. In males, we see abdominothoracic. Can you please look for that in yourself? All good, boys? Abdominothoracic? Good. Okay. Now there is expansion of chest, accessory muscles of respiration. Expansion of chest, we will explain it to you in the procedure. Okay, we'll explain it to you that how do you do it, how do you measure and everything. Fourth comes your accessory muscles of respiration. Your anatomy is on, right? Chest is covered. Can you tell me some accessory muscles of respiration? One. External intercostal muscle. Internal intercostal. One more. Other than intercostal. Okay, you people are aware. Chalo. Very good. Next, we have seen movement of chest wall. So first we saw shape and size, then we saw our movement of chest wall. Now we come to trachea. Okay, trachea is very important. Now how to see trachea ka this one to locate? Palpation, we'll show you in palpation, okay? But here we are discussing about inspection. How do you see it? If the trachea is kind of diverted, you can see it very easily. Okay, it is very easily seen. And that slight movement of trachea into the right, that is also normal. Slightly right deviation of trachea is normal. Okay, if the deviation is more, then it is problematic. That is also called trail sign positive. In trail sign positive, you will also see there is prominence of sternocleidomastoid. I hope you have heard the name. Aware? Good. Now, there are conditions where trachea is moved to the same side, conditions where it is moved to the other side. Say, one condition is pushing the trachea away. One is pulling the trachea towards it. Now, where would it push away? In pneumothorax, pleural effusion. These conditions will push the trachea away. Be very careful, I'll ask. Okay? It'll push the trachea away to the other side. And there will be conditions which will pull the trachea towards it, like the fibrosis. Fibrosis has a habit of pulling things towards itself, stiffening stuff. Okay, fibrosis. Okay. So shift to the other side, pneumothorax, pleural effusion. Shift to the same side, fibrosis, collapse of lung. Think normally, think logically. If the lung is collapsed, it will pull or it will push? Pull, right? All agree? Okay. And some will push it. Like effusion, pneumothorax. Just think it like that. There is this balloon and there is, suppose this one, and there is this balloon. If the balloon inflates, it will push it away, right? Same is your pneumothorax. It will push it away. Okay? Okay. Sure. So here are the conditions. Away in pneumothorax, pleural effusion, tumors. Towards in atelectasis, lung collapse. Lung will collapse, it will pull it towards. Okay? Then pleural fibrosis, lung aplasia, these things. Chalo. Now we come to palpation. In palpation, as we see, we'll feel it. Whatever is there, whatever findings we have found in our inspection, we will confirm it through palpation. Okay? In inspection, anybody has any problem? All good? We are on the same page? Okay. Now we come to palpation. Palpation may position of trachea. What we do is, all of you show me your index finger, ring finger. We'll put our index finger in the head of our sternocleidomastoid, clavicular head of the sternum. Sorry. Point it out. Come on. Point it out. Good. Now we'll put our ring finger on the other head of our clavicular head towards our sternum. We did? Good? All good? Okay. Now, track the trachea. सबका सेड्डा में है? Yes. Below that, no. At the level. ठीक है? Now slightly move it down. Shift it down. Centrally आ रहा है? किसी का deviation है? Yes, ma'am. All good? Deviated है? है तो आप बनेंगे हमारी demo. All good ना? Okay. Now positioning of your apex beat. ज्यादा स्मार्ट नहीं बनना कि यहाँ है apex beat, यहाँ है apex beat. ऐसा मत करना. We know you know, but show them how you know. Okay? Go for the manubrium sterni. Anatomy again. All are aware what is manubrium sterni? Corresponding to your manubrium sterni is your second rib. Ribs. We are aware what is ribs? Great. Now manubrium sterni के side में आता है second rib. ठीक है? Intercostal spaces, can you all count? Huh? You move down on the left side, reach the fifth intercostal space. Are we on the same page? Step 1, identify your second rib. How? Manubrium sterni. Step 2, reach the fifth intercostal space. ठीक है? सब कोशिश कर रहे हैं ना ढूंढने की? हाँ? ठीक है. Fifth intercostal space will reach. Yes sir, any problem? इनका ढूंढ रहे हो? अपना मिल गया? नहीं? ठीक है. बनेगा तू हमारा सब्जेक्ट. हाँ, इसको तू बढ़ा रहा है, हमको नहीं बढ़ाएगा क्या? अब we'll reach the fifth intercostal space. We'll use our palm. Do you know what is hand and what is palm? Okay. We'll use our palm. In the fifth intercostal space, we'll place our palm and we'll try to observe the highest level of vibration which you can sense. After we sense that vibration, we will put the ulnar border of our hand in that line. Ulnar border. Can anybody tell me which one is our ulnar border? Why is it the ulnar border? Yes, good. So we'll locate it with our ulnar border of hand, right? Palm, then ulnar border. Now focus on your ulnar border. The highest level of vibration where you feel, trace it down and point it with your finger. Okay? Palm, ulnar border, finger. That's how you locate your apex beat. Are we good? Any confusion? All good? Okay. Now comes your presence of lymph nodes. Okay? Lymph nodes is something, here we will focus on supraclavicular and your axillary lymph nodes. Okay? In the axilla, you have to do circular motion to identify if there is any enlargement. Okay? If there is no enlargement, everything is good. Okay? If you find kind of any enlargement and stuff, this is present in case of malignancies. There can be other reasons also, but generally when lymph nodes are involved, we call it malignancy. There is a whole different classification, not going into that, simply explaining it to you. Okay? There comes our lymph nodes, axillary as well as supraclavicular. Okay? Now comes our expansion of chest. How do we see expansion of our chest? Please understand this point very nicely. We'll try to elaborate it to you better when we divide it in groups and stuff. Okay? But get this information firsthand. Look, suppose this is this person who's standing in front of me. Let's all imagine. We'll be very creative right now. Okay? Put your fingers like this, your thumbs towards the midline and your palm facing like this. This is the midline. Okay? Now this position will be your 10th rib. At your 10th rib, midline, your thumbs like this. Okay? We'll ask the person to inhale, to breathe deeply. Now what do you think? If the person breathes deeply, what will be the position of our thumbs? Upwards or away? How many upwards here? Upwards, anybody? Enlighten us. Away? Okay. How much away is not too much away? It's 5 centimeter to 10 centimeter. It's normal. 5 to 10 centimeter, it's normal. More than that, there is a problem. Okay? Now this is the expansion of chest. One more thing which we will notice is we'll use a measuring tape. Okay? We'll ask the person to breathe in and we'll measure the chest circumference. Now, where would we measure it? Any idea? At the level of the nipples. Okay? We'll measure it. Exhalation and inhalation both. We'll ask the patient to breathe in. We'll measure. We'll ask him to expire. We'll measure. The difference should be within 4 to 7 centimeters. Okay? Not more, not less. Please remember this. This will really help you out. Okay? These two things are very important. Generally what happens in the examinations when the examiner comes now, they basically ask for these two things. Okay? Be very careful about it. Okay? Expansion of chest is done. Then comes the chest palpation for vocal fremitus. Anybody has any idea what vocal fremitus is? Anybody? When we speak, if our chest? Okay, fine. Sit down. Vocal fremitus is the vibration. Okay, it is the vibration. Tactile vocal fremitus. We observe the tactile vibrations and correlate with our chest, which is done during the act of phonation. This is very complicated. Vocal fremitus means you'll ask the patient to say 1111, 9999, Ram 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 Ram. Okay? We'll ask them to say it, yes, whoever it is, later. We'll ask the patient to go on saying this. Now, not like this 111111, 222222, 19. Okay, where N, R is used. Those words, they create more vibrations. Okay, now when we check for vocal fremitus, we'll do it in the right rhythm. We'll ask them to say 111, 111. Maintain the rhythm, and we will compare. And we will compare. Compare two sides of your chest, right and left. Okay, how? In our hand, what do you think? Which one is the most sensitive part? Remember the apex beat. We localized with our palm. Then where did we go? Ulnar border. Okay? We'll notice it with our ulnar border. Okay? Now where to look for it? Let me explain it to you with, there are certain sections of our chest. You know our clavicle? Everybody is aware they have a clavicle. Above clavicle is called supraclavicle. Okay? Below clavicle is our memory. Below memory is our infra-memory. Supra, infra. No sci-fi knowledge I'm teaching you, common sense. Okay? Supraclavicular, memory, infraclavicular. This is your anterior chest wall. Posteriorly, suprascapular, scapular, subscapular. Okay? Nothing to memorize, very simple. And laterally, axilla and infra-axillary. Okay? Very easy stuff. Only to memorize. Okay? Now, these areas are very important in respiration. We will check for vocal fremitus. We'll ask the patient to sit or stand, preferably sit. Okay? We'll ask him to say 9999. He will say 9999. We'll place our ulnar border in his chest. Okay? First in the supraclavicular region, we'll ask him say 999. He'll say 999. Whatever sensation you're feeling this side, you should feel the same sensation on the other side. Okay? Ask him to say the same thing on this side. Never go like this. Compare both sides. Now the sides are your supraclavicular region of both right and left. Okay? Then comes your intercostal spaces. Are you aware about your intercostal spaces? Can you count them? Yes? Okay. So we'll check for it in the intercostal spaces anteriorly. Posteriorly, what do we do? We'll ask the patient to keep his hands crossed over the shoulders. Do it, everybody. Come on. Do you feel your back is more exposed like this? Yeah? Okay. This way, you check the vocal fremitus posteriorly. Okay? Similarly, right, left. And 999, 999. Not 9999999, not like that. Okay? Like this proper rhythm you should maintain. सब बोल तो रहे हैं, आ रहा है, देखेंगे कितना आ रहा है. ठीक है? ऐसा equal आना चाहिए, 999 बोलेंगे और equal sensations आनी चाहिए. Okay? Like this, posteriorly also you do. The intercostal spaces, you carry on like that. So anterior done, posterior done. Axillary also do it the same way. Okay? Axillary, infra-axillary will be your 5th to 7th rib. You all said you know how to calculate intercostal spaces, right? Huh? 5th to 7th intercostal space or rib. Infra-axillary is that point. Check there. Idhar ek bar. Okay? Compare. The main goal is to compare both the sides. Okay? Chalo. This is your vocal fremitus. Now, why do we measure it? We'll come to that. But first of all, you have understood now the procedure, how to check. Anybody, any doubt? Please tell me. All good? Chalo. Next is your tenderness. If the patient says that's why history. The patient will tell you if there is any trauma or any kind of injury he has undergone. If there is any history, you palpate that place and see if it reacts. If there is reaction in his face, then tenderness is present. Okay? And then we'll continue the diagnosis of that patient in that route. History is very important, guys. Like if there is history for smoking, for many years, COPD comes very easily in our mind. Okay? History is very important. And one most important thing is you ask for smoking ka history. Okay? Yeah, that's your tracheal position. All clear? Palpation of trachea done. See, this is the deviation of trachea to the right side. Can you all appreciate? Everybody can understand now? Chalo. Yeah. ट्रैकिया इधर से देखना है बेटा, इधर से देगा. Remember this one, clavicular head, both side का clavicular head. Then we put the middle finger here. Remember? Try it. Got it? This is what we can see clinically. However, even if you see tracheal deviation, that will not be confirmatory. Imaging is the confirmatory way of medical science. We are not living in the orthodox era where we are so smart कि हम देख के बता दे क्या है. I'm sure there will be geniuses who can do that. But we need imaging for confirmatory. Okay? We go for X-ray then. If you see a deviation of trachea, you still go for an X-ray. Okay? Chalo. So, apex beat, you all have understood ना? कैसे locate करना है? Palm, then finger. Right? Chalo, we are good. Lymph nodes also, you all got ना? हाँ, axilla में देखना है. Supraclavicular में you have to see. आ रहा है समझ में? हाँ हाँ. थोड़ा थोड़ा. कोई भी डाउट है ask me. Okay? कोई भी डाउट हो बेटा ask me. ठीक है? चलो. Expansion of chest, understood? 10th rib, fingers, thumbs दूर जाने चाहिए, 5 to 10 centimeters. ठीक है? See, ऐसे expand करेगा. You see the distance between the two thumbs. Okay? समझा ना? All good? Okay. Tenderness also explained. Vocal fremitus explained. Any doubt? All good? Now, percussion. Percussion is the procedure employed for setting up artificial vibrations in a tissue by means of a sharp tap, usually delivered with the fingers. Too complicated. Let's do one thing. What is your dominant hand? All of you here is righty, na? Any lefties? Lefty hai tu? All rights? Okay. Now you have two fingers. One is your pleximeter, one is your plexor. Your plexor is the hammer. Your pleximeter is over which you ham. Okay? You put your pleximeter finger over the chest wall. Over where? Intercostal spaces. Okay? You put it over the intercostal space. You hit it with your plexor. ऐसे नहीं करना या ऐसे नहीं करना. Only wrist movement होना चाहिए. Okay? In the intercostal spaces and in supraclavicular region. What you do is when you percuss, you will get dull node or resonant node. Over the lungs, you will get resonant node. Okay? Supraclavicular से लेके intercostal spaces, you will get resonant nodes. Over the sixth rib, however, sixth intercostal space, what do you think? What you'll get? How many for dull? How many for dull? Anatomy? Sixth intercostal space में. Okay, six resonant. Resonant? ठीक है, बहुत समझ में आया तूने जो बोला. We will get dull node, okay, because of the presence of liver. Liver की वजह से will get dull node. Okay. Other than that, over the lung parenchyma, you will get resonant node. Okay. Percussion, you do supraclavicular and intercostal spaces. Yeah, go. Yes, come. Intercostal spaces, supraclavicular space. Okay. Percussion. You do it in the axillary region also, infra-axillary region also. You continue the same thing posteriorly also. Okay, posteriorly also you do the same thing in the intercostal spaces. How will you elicit the intercostal space posteriorly? Tell me. ठीक है. What you are saying might be right, but the easier way is this one. Okay, try everybody. Try again. This one. सर आपको तकलीफ हो रही है करने में? आप ही को बोल रहे हैं सर. तकलीफ हो रही है करने में? नहीं ना? करो. बैठ के करो सर. This exposes, हो गया सर. This exposes your back. तो intercostal space को locate करने में easy होएगा. Okay? Back also you percuss. ठीक है? Anterior, posterior, lateral. Done? Any doubt? चलो. Percussion is done to understand the underlying conditions in lungs, pleura, the border of the lungs. ठीक है? Lungs के border तक it will remain resonant, not dull. Sixth intercostal space में आके you will find dullness. This is because of your liver. Understood? All good? चलो. Methods of percussion, explained it to you. Anybody wants to take a picture or anything like that? This is all explained. 2 to 3 inches के ऊपर से you have to do this. And wrist movement होना चाहिए. This is the important thing. Okay? चलो. Supraclavicular intercostal spaces. Okay? Understood now? Chalo. Now comes auscultation. The doctors, with the stethoscope and everything. Auscultation mein you will look for airway, air entry over your lung parenchyma. Anywhere in the lung parenchyma, wherever your lungs are, you will find vesicular breath sounds, except your tracheobronchial tree, the midline. Okay? Anywhere else you will find vesicular breath sound. In the tracheobronchial tree you will find bronchial breath sound. Okay? Normal breath sound is your vesicular breath sound. Bronchial breath sound is normal only in the midline, tracheobronchial tree. There are conditions where you will find bronchial breath sounds elsewhere. But that is a whole different chapter we'll discuss. Okay? First of all, normal breath sound is your vesicular breath sound. And mostly it is there in your lungs. In vesicular breath sound, the inspiration is more audible. It's more intense than the expiration. In bronchial breath sound, there is no difference between inspiration and expiration. I know when I talk to you theoretically, you might not be able to grasp it right. When you'll hear it, it'll be better for you to understand. One more thing you can do is you can try searching and try to put it in your head what it sounds like. Or when you have a stethoscope, just hear it. Okay? The more you hear, the more you observe, the better you understand. Okay? Now vesicular and bronchial breath sound. The The difference is in vesicular breath sound, inspiration mein you will find it more dominant, expiration mein less. Bronchial breath sound mein inspiration, expiration same. Vesicular breath sound is more ruffling. Bronchial breath sound is more hollow. Vesicular breath sound mein you will not find any gap. Bronchial breath sound mein there will be a gap between your inspiration and expiration. This is the basic difference. Okay? Again, this is very theoretical. If it comes in your exam, you can write it. Practically, you have to do and understand. You have to hear more and you will understand. Okay? Theoretical, are we in the same page? Yes? Yes? No? Yes or no? Auscultation, you carry on in the same way. Front mein anteriorly you see. And always compare. If you're ausculting in your right, then go for left next. Don't do right side, then left side. Don't do this. Respiratory examination mein comparison is the main thing, right and left ka. If you see something in the right, immediately see something in the left. Okay? Okay? Chalo. So we'll do anteriorly, we'll do posteriorly, we'll do laterally. Okay? The regions of thorax, anterior, posterior and lateral. Done? Chalo. This all I have mentioned. Now bronchial breath sound. Lung collapse, fibrosis or cavity mein, you can hear bronchial breath sound away from the tracheobronchial tree also. These three conditions. Okay? And this is the same difference which I have mentioned. Inspiration, expiration, gap and all that. Okay? Now vocal resonance. This is kind of same like vocal fremitus, just that you will do it with your stetho. Right, left. Remember the ulnar border? You do it the same thing with your stetho. Okay? Vocal resonance. Right, anteriorly, right, left. Posteriorly also right, left. Then laterally. Okay? Now there are some added sounds, also known as abnormal sounds. Wheeze. Wheeze is a high-pitched musical sound indicating narrowed airways. We find wheeze in COPD, asthma, these cases. Okay? Then we'll find rhonchi, low pitch suggestive of secretions or obstruction. Okay? Then we find crackles, that is crepitations. We generally see it in lung edema cases. Okay? Craps or crepitations which we see now. This is more like one plastic. If we squeeze the plastic, the kind of sound you'll hear, it's like that. Okay? Then comes your pleural rub. This is the friction sound. If there is any friction or any like friction ka sound jo hota hai na, typically that sound. Okay? Chalo. And there is this slide, you can take a picture. This is a very good slide. It will tell you the difference. Percussion mein, when you percuss, whenever there is a consolidation as in there is some solid structure or any hard substance, these things are there, that is called consolidation. Whenever there is consolidation, you will feel dull. Normally, what do we feel? Yes, ma'am? Yeah, ma'am, what do you feel? Normally, क्या सुनने को मिलता है हमको? Resonant? Dull sound मिलता है lungs में normally. Very good, sit down. Resonant मिलता है, हाँ? Resonant मिलता है. Consolidation हो तो dull आएगा. If there is consolidation, you will feel dull. If there is pleural effusion, you will hear dull. If there is pneumothorax, there will be hyper resonant. Okay? Fibrosis में generally normal, लेकिन कभी-कभी कम भी होता है. क्योंकि fibrosis में क्या होता है? There is pulling again. When there is pulling, that will create some air space, which will make it kind of resonant. Okay? This is the slide which will help you differentiate. I hope you all have taken the picture. Chalo. That's all.